Hi there. Thank you for joining today's NILE webinar. This is Emily Rosini. I am the Community Relations Director here at Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, if we should become disconnected for any reason, just call right back in and log back on, and we will continue once we see that most people are logged back on. Second, please locate the chat box in the bottom left of hand corner of your screen. If you have any questions, go ahead and type those questions into the chat box, and we will address those questions throughout the presentation. And then, of course, at the end of the presentation, any last-minute questions will be addressed. Lastly, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure that you complete the survey, which will pop up on your screen as soon as the webinar concludes, or you will also receive a follow-up email post-webinar. All CEUs will be emailed out within the next week, so please give us some time to get those details out and emailed. Before we begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal for our community partners is to gain knowledge on immunization-related topics and through non-branded, unbiased presentations. I'd like to now turn it over to our speaker, Dr. Andrew Kroger. He is the Medical Officer for the National Center for Immunization and Respiratory Diseases at the CDC. As one of the traveling trainers in the Communication and Education branch, Dr. Kroger has given multiple presentations on topics ranging from immunization updates to vaccine hesitancy. I'm going to go ahead and turn it over to Dr. Kroger.
Hi, thank you, Emily, and hello from Atlanta. This is Dr. Andrew Kroger from the Centers for Disease Control and Prevention in Atlanta. Sorry, I cannot be in Nevada to present in person, but I'm very thankful to Nevada State Immunization Program for the opportunity to discuss MMR and MMRV measles outbreak vaccination recommendations. The stimulus for this presentation was a provider letter with guidance on vaccination in the context of the current measles outbreaks that was submitted to health departments on May 17th of this year. I'm going to expand much beyond this letter, actually. I'll kind of talk about MMR, MMRV vaccination generally, as well as other outbreak-related recommendations and resources that have come out since the letter went out. But I will also kind of focus on some of the aspects of the many questions we received from that provider letter. And I do have some outbreak background information as well. This is a map of an update on the outbreak status from January 1st through August 9th, 2019. As of that date, there were 1,182 individual cases of measles that were confirmed in 30 states. This reflects the greatest number of cases reported in the United States since 1992 and since measles was declared eliminated in the year 2000. As of August 9th in 2019, 124 people who got measles this year were hospitalized. 64 of them reported having complications, including pneumonia and encephalitis. Now, the majority of the cases were among people who were not vaccinated against measles, and more than 75% of the cases this year are linked to outbreaks in New York and New York City. Measles is more likely to spread and cause outbreaks in U.S. communities where groups of people are unvaccinated, and I'll talk a little bit more about kind of the characterization of these outbreaks in a few slides. Just a brief update, too. As of August 15th, the number has gone up to 1,203 cases of measles, so an additional 21 cases in that week between August 9th and August 15th. And then this is a complementary bar graph that just shows you the number of measles cases reported by year. This data actually is through August 1st, 2019. Many of you may have seen this data presented on a recent Pink Book webinar. Anyway, in 2019, we've had more cases since there, of course, and we expect this number to change and the bar to be even higher. But the take-home is that there have been more cases this year than in previous years, and we expect the numbers to go up. I couldn't update the slide in time, but anyway, it's now 1,203 people as of August 15th. Majority of cases, as mentioned, are in unvaccinated individuals. On August 9th, there were 5 outbreaks in 4 states. Since August 9th, there is a new outbreak in Wyoming County, which is in New York State. That's over on the western side of the state. The first cases that we heard about were in Washington State. They originated in the Vancouver City area of Washington. The California outbreak is in Los Angeles, and the Texas outbreak is in El Paso. So these outbreaks are occurring in close-knit groups, groups that do not have a strong connection to the healthcare system, so they don't typically receive vaccines, so they're at risk of spread of disease. The disease began with imports from primarily Israel and Ukraine to Orthodox Jews living in Washington State and New York State. The vast majority, 75% of the outbreak cases, now come from the state of New York and New York City, again among Orthodox Jews. The first cases originated in the month of October, and we've had a weekly, the increase of cases every week has been slowing, so there are fewer and fewer new cases every week for about the past 4 to 5 weeks. But it's concerning because we're approaching a duration of outbreak that may eventually cause the World Health Organization to remove the United States status of measles elimination. So that is something that we are thinking about and concerned about. It's been more than 10 months now since these outbreaks have begun. So with that in mind now, I want to kind of talk about recommendations for vaccination. We all need to do our part to make sure we prevent new cases from occurring. Measles is a very contagious disease. I'm not going to go into details of the disease itself, but just there's no other way to really stop the spread except by making sure people don't get infected in the first place, and vaccination is the way to do that. So I'm going to start with just talking about some MMR vaccine recommendations, and beginning with children and adolescents. You know, children have predominantly most of the infections, rather, in these 2019 outbreaks are among children. If you recall, the provider letter that was sent out was focused on adult vaccination, and we have received a lot of questions and clarifications needed about adult vaccination. But I think it's important to realize that these are infections occurring in children and adolescents for the most part in these outbreaks. So cover the recommendations, of course. MMR is recommended. It's a 2-dose series. The first dose is recommended for children between 12 and 15 months of age. The minimum age for the routine dose is 12 months. Now, you may begin earlier than that because for international travel, for a child going to a country that is endemic for measles or has measles epidemics, children who are at least 6 months of age, ACIP does recommend a dose of MMR to be administered for the travel. This is an off-label use of the vaccine, but it is a recommendation from the ACIP. So that's an important disclosure there. When a dose is given before 12 months of age, As you know, we give it to prevent disease, but we also know that that dose won't be as protective as a dose given later in life because of interference from mom's the maternal antibodies from mom during the pregnancy, which do last for 6 to 9 months after birth. So that dose doesn't count, and so it's given before 12 months of age, and 2 more doses will be needed. There is a grace period. I'll mention 4 days before the first birthday can count as the 12-month dose as well. So the second dose of vaccine for routine is recommended at 4 to 6 years of age, but it can be considered valid as long as it is given 4 weeks after the first dose. So this can be an issue as well with international travel. We tend to recommend not waiting till 4 years of age, but making sure the second dose is given if the child is traveling and it has been at least 4 weeks since the first dose. And again, a 4-day grace period can also be used between that 4-week interval between 2 doses of MMR vaccine. Note that the second dose is not technically a booster dose. The first dose provides a strong response, 93 to 95%. But we recommend the second dose mainly to produce immunity in persons who for some reason didn't respond to the first dose. It's an insurance dose and bumps it up to 95, 97% protection, maybe even a little bit higher than that with 2 doses on board. So again, after that, persons are protected for life and they do not need routine booster doses. I believe first published in the 2003 child schedule was Ketchup of the second dose for all children and adolescents through the 19th birthday, through 18 years of age. So that's another important consideration is we recommend those 2 doses, but no boosters after that. MMRV is a combination vaccine that contains not only the measles, mumps, rubella component of the MMR, but also contains the varicella component, chickenpox vaccine. This vaccine actually is only licensed through age 12 years and only recommended through that age as well. We tend to recommend a 3-month interval. Well, the routine ages are still recommended for this vaccine, of course, 12 to 15 months and then 4 to 6 years of age. When we're deciding about giving an earlier dose with 2 doses of MMRV, we like there to be a 3-month interval between 2 doses instead of a 1-month interval for issues such as travel and things of that nature as well. Now, on the next slide, I've got an outbreak-specific kind of add-on here. I've mentioned international. Measles is epidemic, endemic in other countries. So that's why international travel is a risk. For measles, domestic travel now in the context of these outbreaks has been considered a risk as well. And so as there's an earlier dose that can be given, an extra dose for internationally traveling children, you can also give an earlier dose to a child that is traveling domestically. It is the discretion of the health department at the destination site domestically. So if the destination is routinely vaccinating infants early because of a local outbreak or whatever reason, it's reasonable to do the same for someone traveling to that region. It's basically the discretion of public health at the destination to give that early dose. So that's an important consideration, something new with this outbreak, and is in the guidelines as well. Now, within the past month, CDC posted guidance for measles disease screening and vaccination guidelines for children heading to summer camps. This was in response to anticipated travel of Orthodox Jewish campers to camps in upstate New York. The website at the bottom of the slide shows you where this camp guidance can be found. The first two bullets: be prepared before camp opens and document the vaccination status of camp and staffers. That was relevant probably a month ago when this was first posted. Summer in the South is coming to an end. There's a few weeks left, I guess, in the West and the Northeast of the United States. The two bullets are basically the guidance for this past summer to make sure that campers are screened. And it was focused on local concerns. But relevant nationally is a new tool that was part of this camp guidance. It's a video that will allow providers to, and also can help with others at the camp identify a case of measles. It's a new video that was posted at the website www.cdc.gov/measles/toolkit/healthcare-providers.html. On that site are actually 3 videos. It was one production, but we kind of created different videos with different levels of detail, all drawn from the same original recording, on how to diagnose measles. So it's a very useful tool. And then, of course, the last bullet: any suspect measles cases need to be reported immediately to the local health department. Okay. Now moving on to adults. Adults are generally at lower risk of measles than children. Many adults received vaccine previously or actually had measles disease when they were younger. Now, measles was declared eliminated from the U.S. in the year 2000. So over the past decade or two, there are actually many adults who fortunately have not had the opportunity to have immunity from disease, right? They may have immunity from vaccine, but not from the disease. So this is of increasing concern, and will be in the future, about determining whether an adult is still at risk for measles disease in an outbreak setting. And again, we received a lot of questions on how to determine this. When you're deciding about whether an adult can be considered already immune and therefore not at risk of infection, or whether that same adult is actually susceptible to measles, we use the following criteria that are listed in the third bullet. There are 3 sub-bullets. The criteria are age-appropriate vaccinations, that's documented vaccination, documented laboratory immunity, which could be the result of from vaccination or from disease, and the third criteria is birth before 1957. If any one of these criteria are obtained, or if an adult meets one of these criteria, and only one, that adult is not considered to need a dose of vaccine. Now note that birth before 1957, that criteria should be ignored for healthcare providers. Essentially, we want providers to be vaccinated, and birth year as a criterion is really just based on an epidemiologic trend of likelihood of immunity from disease. It is not absolute. So even healthcare providers born before 1957, we tell healthcare facilities, consider them susceptible. They should be consider those healthcare providers for vaccination, even if they were born before 1957. And those older healthcare providers should definitely be vaccinated if there's an outbreak in the healthcare facility or in an outbreak setting. So that's the way to establish criteria of immunity. The provider letter started off with this dichotomy of 1 dose versus 2 doses for adults. Now, as mentioned on the previous slide, some adults don't need any doses. But if an adult does need a dose, you do need to make this decision. An adult, by the way, is 19 years of age or older, about whether they need 1 dose or 2 doses. And so adults most are recommended for 1 dose. Those adults recommended for 2 doses of vaccine include students at post-secondary schools, healthcare personnel, international travelers, and that's essentially it. I'm going to talk a little bit about different types of vaccines received in the past in a little bit, but that's basically how you know whether an adult needs 1 dose or 2. The issue of travel is applicable to adults as well. As mentioned, there are adults who need only 1 dose, but if they're international travelers, they need 2. Well, what about adults with domestic travel in this outbreak setting? Again, it's akin to the same discretion we give before for the infants. If adults traveling to a destination are receiving 2 doses by routine, then the public health department can share that with the traveler or the traveler's provider, and then adult traveling there could receive a second dose as well. Don't confuse this with a recommendation for 3 doses of measles vaccine. We don't have a recommendation for 3 doses of measles vaccine, although some adults will receive 3 doses of MMR vaccine because of mumps outbreaks. That's a different issue and a different set of guidance. That's not really a part of the measles outbreak recommendations. So to recap a little bit this letter, it asked the provider to think about 1 dose or 2, and then it kind of talked about ascertaining immunity. I think the reason we did this really is that we wanted to focus on those adults that really needed the vaccine. We're thinking of healthcare providers and international travelers primarily. So, those adults that lack evidence of immunity, you then carry out the calculus to determine whether they need 1 or 2 doses. And especially, healthcare providers, they're going to need 2 doses if they lack evidence of immunity. So I think that's kind of why we kind of focused on that in our communications guidance. And we received a lot of questions about how many doses are needed. So the letter focused on that. Beyond the provider letter, there have been other postings to CDC's webpage. I've got the URL at the bottom on recommendations for infection prevention and control in healthcare settings, which essentially states that to ensure that healthcare providers are immune to measles, minimize potential exposures to measles, adhere to the standard and airborne precautions. Remember, measles is considered not only transmissible through droplet, but the small droplet nuclei, so it is considered airborne. Measles remains in a room for 2 hours after a patient with measles has left that room. So managing the exposures, managing measles outbreaks. I'll talk a little bit about that on the next slide. Making sure providers are trained and educated, and the reporting guidance that exists for all in the public health context also should be instituted within the hospital itself. A culture of reporting when a case is suspected. And then, of course, also reporting to public health when a case is suspected. Now, one of the follow-up questions we've received about management of healthcare providers exposed to measles derives from this guidance. Obviously, if a healthcare provider has evidence of immunity to measles and has an exposure to measles, is really prophylaxis is not necessary either with vaccine or passive products. There's no need for work restrictions. We would still recommend the daily monitoring for signs and symptoms of measles in that healthcare provider for 21 days after last exposure. So that's for those that have immunity. Those who don't have immunity healthcare providers, that is, who don't have immunity and they've had an exposure to measles need to receive post-exposure prophylaxis, and that's going to be, preferentially with vaccine, with MMR vaccine, but there is IG as well for post-exposure prophylaxis, and then with work exclusion from the 5th day after the first exposure until the 21st day after the last exposure. And that's regardless of receipt of post-exposure prophylaxis. And we've gotten a lot of questions about that. What if someone receives their intervention, let's say MMR vaccine, or IG after the last exposure? Does that change? Do you have to wait longer? And the answer is essentially no. Last exposure means the last exposure before vaccination. The healthcare provider is, by routine, monitored for signs and symptoms of measles infection for 21 days after the last exposure. That monitoring may be extended if the provider received IG instead of MMR vaccine. We definitely make that distinction in non-healthcare providers. If you receive IG for post-exposure prophylaxis, it can extend the incubation period beyond 21 days. So it makes sense to do that for healthcare providers as well. But we don't extend the exclusion from work anymore. It's really exclusion from work is 21 days after the last exposure, regardless of whether they received post-exposure prophylaxis and regardless of whether that was MMR or IG as the tool. And again, during a measles outbreak, be sure to administer measles vaccine to healthcare personnel in accordance with CDC and ACIP recommendations. So again, that might involve a dose for, probably not an extra dose for a healthcare provider. They're recommended for 2 doses anyway, but they should receive vaccination either by routine or as post-exposure prophylaxis. If they have measles, if the healthcare provider comes down with measles disease, they should be excluded from work for 4 days after the rash appears, with rash onset considered as day 0. If a healthcare worker is immunosuppressed and they get measles, they need to be excluded from work for the duration of illness. So a lot of information, and there's follow-up information on the website itself. Now I'd like to discuss some issues related to vaccination of adults, questions we've received, clarifications needed. First of all, for adults, do past doses of vaccine count? The answer to this question generally is yes. So it doesn't necessarily, it's not only adult vaccine doses given in adulthood that count, but doses given in childhood count as well. The exception is a dose administered between 1963 to 1967. And the vaccine recipient cannot recall whether the vaccine was live attenuated or inactivated, or if they're certain that the vaccine was an inactivated dose. So there was an inactivated measles vaccine that was not effective in preventing measles or establishing any type of long-term immunity. So those doses don't count towards immunity and documented doses to establish immunity. Also, doses administered in infancy, it's relatively new that we're recommending doses administered in infancy for international travel, but I've already mentioned those doses don't count towards the routine as well. Another exception is kind of not really related to this issue, but but it has an impact. Doses administered before 1979 don't count as a dose of mumps vaccine. So regardless of considerations of measles immunity, many persons who received MMR before 1979 are going to be recommended for another dose of the MMR vaccine, which will provide yet another dose of measles vaccine as well, because it's a combination vaccine. They're all in the same vaccine. The question about ketchup always comes up in our guidance as well. Do adults need to be caught up based on the adolescent 2-dose recommendations? The answer is no. It may go back before 2003, but I looked back and it showed up on the child schedule that we had full ketchup recommendations where all adolescents need those 2 doses. But adults who are recommended for only 1 dose of MMR vaccine currently, in other words, considered low risk, and had received a valid dose, and they know it was not the killed or their unknown measles vaccine, and even if they received that dose in childhood, they don't need a second dose of MMR simply because we have a catch-up recommendation for 2 doses for adolescents. So that's what the guidance means whenever it says that you don't have to catch up adults. Catch them up on the basis of the adolescent recommendation. What about the titers? I mentioned laboratory evidence of immunity, so that's a serologic test or titer. We don't really recommend doing these tests routinely. The tests are 80% sensitive, but less sensitive to detect immunity based on a previous dose of vaccine. So you can use a titer to see if someone is protected from disease, but not so much if they're protected on the basis of vaccination. And if someone has age-appropriate vaccination, ACIP actually recommends ignoring any result you get if you do that titer after your second dose of vaccine or the final dose of vaccine. So there's no sense in doing it because you ignore the result. The actual documented history of vaccination is enough to establish immunity. But that doesn't mean that it doesn't happen often that titers are done. People sometimes just had the titer done in the past. Sometimes rubella titers are needed in pregnancy, and measles and mumps will come along with we'll do that laboratory test as well. So it's important to realize that if the titer is done and it is positive, that they are specific. So if a titer for measles is positive, that's fine. You have evidence of immunity, and you are considered immune. We just don't recommend, ordering them ahead of time. You're lucky if you get a positive result on these titers because of the lack of sensitivity for vaccine-induced immunity. And they're not really cost-effective in the sense that they lack mump specificity. They're neither sensitive nor specific for mumps. So titers, they cause a lot of confusion in terms of understanding what a result means. So we don't recommend titers for that reason in the mumps context. So they're generally not covered by insurance either because of that. It is more cost-effective and simpler when faced with the decision of establishing immunity to just give a dose of vaccine and not do a titer. Additional doses of vaccine are not harmful. Remember, we recommend an extra dose of MMR vaccine for the mumps protection and mumps outbreaks. And also, if a dose is not documented, we don't consider it to have been given. So everyone who doesn't have records gets conceivably extra doses. If they, just because they don't have a record doesn't mean they didn't receive it, but yet we recommend the dose in the absence of documentation. So it's just going to boost the response that's already there and is safe to do. So there's no problem with administering doses as a way of establishing immunity. And so on the note of safety, I do have some information about adverse reactions from MMR vaccine. All 3 components of the vaccine are live viruses, so adverse reactions following vaccination are predictable. They represent viral replication that leads to various conditions that you would expect from the disease, but the symptoms are milder and they resolve generally without treatment. They also, you can be clued in as a provider that these outcomes might have been caused by the vaccine if they occur an incubation period after the vaccine was given, because the incubation period is the same whether we're talking about vaccine virus versus wild-type virus. So, and the most common of these reactions are probably fever. For systemic reactions, they occur in 5 to 15% of the recipients. A lot of people know about the febrile seizures that can occur as well with MMR. The risk of that is 1 case in every 3,000 to 4,000 doses of MMR vaccine administered. The rate is actually higher with MMRV, twice as high. So that's notable. When someone has a history of febrile seizures, we typically do not recommend MMRV. We recommend MMR. The varicella titer is high in MMRV, so and we actually think that may be contributory as well towards why the febrile seizure occurred. Rash occurs in 5% of recipients, lasts about a day or two, could be caused by the measles component or the rubella vaccine virus, but this rash is much milder than the rash that occurs with disease. Fewer numbers of lesions. Sometimes the lesions appear a little bit different. They may be kind of macular as opposed to maculopapular. Thrombocytopenia has been known to occur, low platelet counts in 1 to 30,000 to 40,000 vaccine recipient doses. It's usually transient and benign. Lymphadenopathy is rare and is generally thought to be due to the rubella component. Allergic reactions are rare, and then parotitis and hearing loss are other very rare adverse events that can occur, thought to be due to the mumps component of the vaccine. Now, I got a slide of the adult schedule. I want to highlight the second row because I'm going to talk about contraindications. There are essentially 3 important contraindications: pregnancy, immunocompromised, and then as a subset of that, severe immunocompromise from HIV infection. But there are a couple others that are contraindications you need to know about. First of all, a history of anaphylaxis to a vaccine component, and the MMWR highlights neomycin, but it could be any component in the vaccine. Neomycin probably is the most common allergy, intrinsic allergy of the components in the vaccine. The vaccine also has gelatin. The vaccine doesn't include ovalbumin or egg protein. This first contraindication also applies to MMRV, of course. The immunosuppression is considered a contraindication for MMR and MMRV. It's a live vaccine viruses. If someone is immunosuppressed, whether due to disease or drugs, you could have uninhibited viral replication. Patients with immunosuppression, bone marrow transplant patients have been known to have severe cases of pneumonia following inadvertent vaccination with these vaccines. Patients with HIV as well. Pregnancy is a contraindication. It's a theoretical risk whenever we have a live vaccine. Pregnancy is considered a contraindication. What you should do in this circumstance is, if you're screening a woman of childbearing age, ask if they are pregnant or likely to become pregnant within the next 4 weeks. If they say yes, then withhold the vaccine. Do not give it. It's a theoretical risk based actually on studies that looked at antibody levels in the fetuses of mothers that were inadvertently vaccinated, but there's no evidence of any adverse reaction that ever occurred following a dose of MMR vaccine given in pregnancy. So we do consider it a contraindication. It's off-label recommendation. The package insert says 3 months, but ACIP kind of did a feasibility analysis. This was like a long time ago. There is a posting of the guiding principles for vaccination and pregnancy, and determined that it doesn't make sense to make someone kind of defer pregnancy for more than 4 weeks after a dose of vaccine. These live vaccine viruses replicate in 2 weeks, and then they stop replicating, and there's no risk after that. So they added 2 weeks, and it's a 4-week recommendation to wait to avoid conception for 4 weeks. If a woman is inadvertently vaccinated while pregnant, she should be counseled and should basically be kind of told the same things I just said, that there's no reports of actual harm to a fetus. It's based on, any kind of risk of outcome is based on data on response to the vaccine and not on actual outcomes. So definitely it's not, MMR vaccination during pregnancy should not be considered an indication for termination of the pregnancy. A first-degree family history of a congenital hereditary immunodeficiency. This is a contraindication. It basically is applied in the first year of life, and so really is only relevant to that international travel decision to vaccinate infants between 6 months and 11 months. If there's a family history of a congenital immunodeficiency, then that infant themselves, the potential vaccinee, may also have the same hereditary immunodeficiency. And so our recommendation is to determine if the vaccinee has the same condition. If not, then they can receive the vaccine. So we're talking about essentially first-degree relatives. That's how far you need to look to when you're screening. And by a year of age, it should be known whether a congenital hereditary immunodeficiency exists in the child. Precautions to vaccination. I'll just mention, I've got those later, so I don't need to talk to in a later slide. Immunosuppression can consist of disease like primary immunodeficiency diseases. Any type of blood cancer is considered immunosuppression and a contraindication: leukemia, lymphoma, multiple myeloma. Other organ cancers that are metastatic are immunosuppressive. Someone who receives a solid organ transplant, they are considered immunosuppressed for a period of 2 months after their transplant. HIV, if someone has HIV, they very well may be immunosuppressed, but not always. Now, when HIV is diagnosed in the perinatal period, they generally are immunosuppressed. They go on medications, combined antiretroviral therapy or CART. So if they should not be vaccinated at this time. If they are vaccinated, they're going to need to be revaccinated 6 months after they've achieved immunocompetence, which does occur in HIV infection following therapy. And for others, you want to make sure that someone is immunocompetent before you provide a dose of vaccine. Someone who's immunosuppressed because of anti-cancer drugs, you want to make sure, if they're on steroids, they need to be off the steroids for a month. Pretty much all of the other, most of the other immunomodulators, it's 3 months. Antimetabolites, alkylating agents, radiation therapy, anti-transplant rejection, tumor necrosis factor inhibitors. It's a 3-month period. You have to be off the drugs, and then you're considered may be immunocompetent. It really is a provider's decision because it's not only based on the medication but the disease. But autoimmunity is not immunosuppression by definition. So it's not autoimmunity that would be the concern in that case. It's just the medications. So if they're off 3 months, then they're immunocompetent and can then give MMR, MMRV vaccine. And then certain types of anti-cancer drugs, lymphocyte depleting agents, checkpoint inhibition. And it's not only anti-cancer, it's disease-modifying anti-rheumatic drugs as well for prevent arthritis or treat arthritis. Some of them really pack a punch and cause immunosuppression such that we would recommend waiting 6 months. So that's the lymphocyte depleting agents and checkpoint inhibition. Now, HIV, I want to talk a little bit more about that. If someone has HIV but is not immunosuppressed, they're immunocompetent, they need to receive MMR vaccine. They are at high risk of disease from the wild-type virus, particularly measles, and so they need to have the vaccine. We do contraindicate MMRV. Got the high varicella titer in it, so we don't recommend that vaccine, but MMR, they need to receive it. They should receive it after 6 months of being considered immunocompetent, which is defined as having a CD4 percentage of 15% or greater for persons 5 years old and younger, or a CD4 percentage of 15% or more, and a CD4 count of 200 lymphocytes per cubic millimeter or more for the persons older than 5 years of age. We'd like both parameters to be there. If only CD4 counts or CD4 percentages are available, you can assess this on the basis of whichever lab result you have, counts or percentages. If you don't have CD4 percentages for those 5 years old or younger, then there are age-specific CD4 counts that exist, and they're age-specific. So someone who is younger than or equal to 12 months of age needs to have greater than 750 CD4 lymphocytes per cubic millimeter. If they're 1 through 5 years of age, they need to have 500 lymphocytes per cubic millimeter. And then if they're 6 years or older, they need the 250, which is kind of the standard through adulthood to be considered immunocompetent and able to receive vaccine. Household contacts of immunosuppressed persons need to receive the vaccine. The vaccine viruses are not transmitted through normal mechanisms to immunosuppressed persons. Rubella vaccine virus can be transmitted through breastfeeding, but as far as someone who's vaccinated being in contact with other immunosuppressed persons, there is no risk of transmitting their vaccine virus to that person, so they should be vaccinated themselves, the household contact. It will protect them from disease, and therefore they won't be able to spread disease to their immunosuppressed household contact. Even if someone receives MMR vaccine and they have a rash, the vaccine viruses are not transmissible from that MMR vaccine rash. Precautions for MMR and MMRV include moderate or severe acute illness. If someone's sick, you can wait till they're better before giving a dose of vaccine. If they've had a recent blood product, that blood product may contain antibodies to measles, and those antibodies could interfere with the vaccine. So there's a variable amount of time you need to wait before you vaccinate. That's in the Appendix A of the Pink Book, or it's in the General Best Practice Guidelines for Immunization. And then a person or family, meaning a sibling or parent, history of seizures, whether febrile seizures or not, that's a recommendation to receive, that's a precaution for MMRV. So we would then state that MMR is the vaccine of choice and with separate varicella vaccine, but not the combination MMRV vaccine. Again, the titer of varicella antibody in the combination varicella product, MMRV, is higher than in the single dose varicella product. So you are giving, by giving the two separate vaccines, MMR and varicella vaccine, on the same day, but as separate component vaccines, you're providing less antibody and less concern for fever and febrile seizures. To prepare these vaccines for administration, they need to be reconstituted. It's reconstituted with sterile water supplied by the manufacturer. It's administered subcutaneously with a 23 to 25 gauge needle and a 5/8 inch needle. That's the needle length for all ages for subcutaneous vaccination, and the site is the upper outer triceps of the arm or the anterolateral thigh. As far as storage and handling, it's a live vaccine, but this one actually can be stored in the refrigerator or the freezer. So we state in this slide, store in the refrigerator between 2 degrees Celsius and 8 degrees Celsius, 36 to 46 Fahrenheit, because the diluent should definitely be put in the refrigerator. Don't put the diluent in the freezer. You generally want to keep the pellet powder and the diluent together, so keep them both in the refrigerator. After reconstitution, you want to make sure the vaccine is administered, and you need to discard it if it's not administered within 8 hours after reconstitution. Don't draw a reconstituted vaccine into a syringe until you're ready to administer it. But you can also store MMR in the freezer, and MMRV has to be stored in the freezer because of the varicella component. So at negative 50 degrees Celsius to negative 15 degrees Celsius. Do not use dry ice. This vaccine needs to be protected from light. If you remove the vaccine from the freezer, you can put it in the refrigerator temperature for 72 hours, continuous hours. You don't want to be moving it back and forth between refrigerator and freezer, or refrigerator and room air, for that matter. Once you take it out into room air, you have 30 minutes to administer the vaccine. Once you reconstitute the vaccine, you cannot freeze the reconstituted vaccine, and discard if you don't give it within 30 minutes. So with that, I'm going to give you a list of resources, and these are the resources we share with persons that send information to NIP Info about the measles response. You can see each URL, each subcategory has its own URL, and I do want to also share the resources guide, the ACIP guidelines, which I talk mostly about, as well as the schedule and everything I talked about with altered immunocompetence and MMR vaccine is in the general best practice guidelines. So with that, I will conclude and take any questions that we may have.
Thanks, Dr. Korber. We do have a couple of questions, and I want to give everyone an opportunity to type in any last-minute questions in the chat box. So feel free to go ahead and do that right now while we go through some of the questions and then address additional housekeeping. So we have one question that says, we typically counsel women that the theoretical concern with getting a live vaccine during pregnancy is that in rare cases it could cause them to develop the actual disease the vaccine is designed to protect. Example, they would get rubella from the MMR vaccine, and having rubella during pregnancy would be the concern. But if she heard you correctly, she thinks that you said the theoretical concern has more to do with the antibody levels and the response to the vaccine. Can you clarify what you mean by this, and or direct us to the resources that further explain the theoretical risk specific to pregnancy?
Yeah, basically the data, there was a quantitative risk established in pregnancy following receipt of MMR vaccine. There's a discussion of, there's actually, it suggests that the risk is not zero when you read risk of adverse reactions due to administration of vaccine in pregnancy. And that safety data is not based on actual outcomes that occurred. It's based on laboratory data that suggests that the fetus was exposed to the vaccine. So antibody levels in I don't remember specifically if it was in cord blood or in the fetus blood or in the newborn's blood, but there was no disease in the newborn. It was basically a result based on exposure to vaccine components and not actual outcomes. And that can be found. I'm trying to remember now, but it's in the 2013 MMWR document. There are references for this contraindication, and those references can go into a little more depth on kind of the actual safety surveillance that was done. But I think the important point is that it's a theoretical risk, so there's recommendation to kind of basically say that there's that antibody levels may be there, but there's no evidence of any disease that ever occurred in an infant that was exposed to vaccine during pregnancy. And so, there's certainly, if the question comes up, there's no reason to terminate a pregnancy if, MMR is administered inadvertently during that pregnancy.
Great, thank you. And then we have another question that came in. If MMR is drawn up in a syringe and not administered, can it still be used within 8 hours?
If that's a good question. We have a general best practice that to accommodate our mass vaccination settings, that vaccine that is drawn up should be used in that clinic day. And so, excuse me. So it's a qualified, yes, in the sense that you want to make sure you administer. We do have a statement. So if you draw it up and you don't, because if you draw up the diluent, you're going to reconstitute the vaccine. And then if you draw up that, you have your 30-minute window. So I guess the answer is kind of no because of that. I mean, we have these, we don't want it. Let's see. Oh, sorry, it's 30 minutes for MMRV and it's 8 for MMR and 30 for MMRV. So that makes sense to me. If you draw it up, you have our clinic guidance. You need to, when you have pre-filled syringes and you take them out of their storage or you draw up vaccine in a mass setting, you basically, are going to, it's going to be an 8-hour period probably. There are clinics that last longer than that in outbreaks, and I guess in that circumstance, follow the 8-hour rule and discard it. So even if your clinic's still going on. And with MMRV, because you took it out of the freezer or refrigerator, you really only have 30 minutes with that vaccine.
Okay, thank you. All right, I'm going to go over a few housekeeping items. So if you have any last-minute questions, now is your chance to ask those. Thank you again, Dr. Kroger. Before we say goodbye, I just want to let you all know that while we are waiting for those questions to be typed in, just a couple of reminders. You have, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure to complete the survey. That will pop up as soon as this webinar is over and you exit out of the ReadyTalk system. Another screen will pop up, so go ahead and answer that survey. It'll be done, and then we will have you on record as completing the survey, and we will go ahead and send out your CEUs via email. So give us about a week to do that. If you don't see your CEU by next Wednesday, then go ahead and reach out to us and let me know. I guess that concludes the rest of the webinar. Thank you so much for everyone who joined, and Dr. Kroger, thank you again for your time. Bye-bye.
Thank you. Bye.